evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. C.B. Patil. Sir is MBBS, MD, DM Cardiology, FIC, FIAMS, FCSI, FIE, WHO Fellow in Interventional Cardiology, USA, visiting cardiologist at Sri Shankara Cancer Hospital and Research Center, Shankarapura, Bangalore, teaching faculty, Department of Cardiology at Manipal Hospital, Bangalore. Sir is also a visiting cardiologist at GM Healthcare, Uttur, Bangalore. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is non-ST elevation, myocardial infarction, STEMI case study and diagnosis and management. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. Thanks for the IGCP for having given me an opportunity to talk on this subject. As you know, cardiovascular diseases are the major causes of deaths among both men and the women. Almost 38 to 44% of the deaths are cardiovascular causes only. And in India, it is of a much more importance because almost 11% in the urban areas they are suffering from the coronary artery disease, and about 6% in rural areas are having this disease, and it is more recently occurring in the young men and the women. That's why the importance of knowing about this. And I'm just going to discuss on the topic is what is including both non-STEMI and STEMI. Non-STEMI is non-ST elevation MI and STEMI is ST elevation MI. They all come under the group called as a acute coronary syndromes. Amongst these acute coronary syndromes, non-STEMI forms about 40% of the diagnosis. And let me just take you for the pathogenesis and the pathology there, what is happening in acute coronary syndromes. As you know, the major causes of all these is coronary artery disease itself with a plaque burden inside, what is called as atherosclerosis. Whenever there is a plaque burden is increasing and when the necrosis of the fat occurs inside with a severe inflammation, inflammatory markers, all these things. So when there's a thin fibrous cap covering on that, due to the shear stress and strain, as well as the inflammatory markers and inflammation, there can be a rupture of the plaque, and that whatever contents they come out, the tissue factor, all these things, they lead to the formation of activation of the platelets. They get aggregated, and along with the tissue factor, all these things, coagulation cascade is initiated and thrombus formation occurs. When there is a complete occlusion of the vessel with a severe ischemia, beyond that, that leads to STEMI. If there is a non-occlusive thrombus, that leads to non-STEMI. So this pathology is very, very important. And you must know what are all the risk factors for the coronary artery disease. The major risk factors being, if the age is more than 45 years in a male, more than 55 years in a female, we are prone to develop coronary artery disease, atherosclerotic. Family history, if there is a premature ASCVD in a male, if they more than 65, within 65 in a male, within 55 in a male, and within 65 in a female, if they have suffered from a coronary artery disease in the first degree relatives, then definitely chance that this man also is, or woman may also be prone to develop the CAD. And apart from that, current cigarette smoking is a very, or a tobacco use of any kind. High blood pressure, anything more than 140/90, especially 180/110, all these things, they are high risk. And low HDLC. HDLC is a good cholesterol. If it is low, it can only increase with our good habits like walking regularly, maintaining the body weight, as well as the diet, all these things. Other high risk features who can develop a CAD is diabetics. especially more than 10 years. If there's already a CKD, if it is there, familial hypercholesterolemia, if it is diagnosed in the families, extreme of a single risk factor, whatever I have already explained to you. If in the coronary CT score, that is calcium score, if it is more than 300 Hounsfield units, and non-stenotic carotid plaque, if it is diagnosed, or if you have checked any time lipoprotein A, if it is more than 50 milligrams. So these are all what are called as high risk features. And other non-conventional risk factors like increased carotid intima media thickness, impaired fasting glucose, increased waist circumference more than 80 centimeters in a female, more than 90 centimeters in a male, apolipoprotein B levels more than 110 if it is checked, and HSCRP, which is an inflammatory marker, if it is more than 2 milligrams, these are all high risk features to develop a coronary atherosclerotic cardiovascular diseases. And depending on number of risk factors, especially if there is a pre-existing ASCVD or diabetes, more than two major risk factors, familial homozygous hypercholesterolemia, they are very high risk. If what is the extreme risk we call, if there is already a coronary artery disease which has developed with more than one feature of high risk group, then they are called as extreme risk category A. And if there is already a coronary artery disease with more than one feature of very high risk group, or recurrent CACS already, again one more MI occurring on a old myocardial infarction, or all these are extreme risk group who need to take maximum care. So just to introduce what is the acute coronary syndromes. So age, I have already told you. Sex, males are more common. Risk factors also has been discussed. So chest pain, if there is a gradual, so in a ACS it occurs over minutes. Whereas if it is sudden, we have to think of other causes like pulmonary embolism, wherein acute breathlessness is more common. Aortic dissection and pneumothorax can be there. The character of the pain is which I am going to again describe to you. Whereas in a pericarditis pleurisy, there will be more of a stabbing type of pain, and musculoskeletal pain also can be there. And gastrointestinal symptoms, if they are there, you have to think of a gastrointestinal causes. And of course, it's a retrosternal pain in an ACS, and maybe radiating to the left arm or the left shoulder, maybe both shoulders, rarely to the back or the epigastrium. All these are very important. And now, what is, I told you the CAD is the main culprit or the cause for this acute coronary syndrome. Rarely superadded spasm can be there. Myocardial bridge, coronary anomalies, they are all very rare causes. Don't bother about that. What we are interested is a coronary artery disease mainly, and rarely even spontaneous coronary artery dissection, which can occur in pregnancy. And proximal aortic dissection can occur in a hypertensive individual for a long time when BP is not controlled. And very rarely coronary emboli due to infective endo. There are, so don't bother about them. Let us discuss what is the main cause. So as you know, what is an angina? It's a diffuse deep retrosternal pressure or a squeezing or a burning type, and rarely associated with a shortness of breath, especially in elderly or women, and can lead to weakness, rarely associated nausea, vomiting can be there, sweating can be there. Some people complain of palpitations. And this pain, I have already told you, it can radiate. Angina can occur if it is occurring at rest or precipitated by minimal exertion, and maybe even sometimes emotional stress, or in a cold weather also it can be precipitated. Usually angina is relieved by rest or a nitroglycerin tablet. If this angina is continuous beyond 20 minutes, then it can be an unstable angina, maybe a crescendo type, that means it is increasing type. If it is more than 30 minutes, that means very severe angina. If symptoms are severe, weakness, nausea, vomiting, along with pre-syncope, and of course with ECG changes, you must suspect a acute myocardial infarction. So this you must know, the man Samuel A. Levin described this sign. Any person coming with a fist over the chest, and complaining of a pain is very typical of an angina. And this figure also you should know if there is a central pressure, squeezing, gripping, heaviness, tightness, if it is exertional related, stress related, retrosternal, left sided, dull or even aching pain, all these indicate that probably it is an acute coronary syndrome. Whereas sharp, flitting type, shifting type, pleuritic, they are all unlikely to be an angina. So signs may be normal, there may not be any signs, maybe tachypnea, tachycardia, hypotension can be there if there is already a myocardial infarction. If there is a pulmonary edema, you can get crepitations, third heart sound, fourth heart sound, MR murmur, mitral regurgitation murmur may be heard during angina. What are the angina equivalents? I told you in young women, elderly who almost form one third of the acute coronary syndrome patients, and diabetics especially can have atypical presentation in the form of a maybe a throat or an abdominal pain, shortness of breath, only just nausea, only just vomiting, sweating can be there, syncope can occur, weakness can occur, dizziness can occur, lightheadedness. These are all atypical symptoms, I told you, especially in elderly. Rarely in elderly, unexplained falls can be there. Delirium may also be seen. In women, prodromal symptoms are more. Chest pain is almost equal to men, but they can have a jaw or a neck or a back pain can be there. Even a simple fatigue can be there in women as a manifestation. So let me just discuss with a case as such, a case of NSTEMI, 63-year-old male, a diabetic, chest pain since 3 days, continuous type of pain almost, retrosternal, and is increasing after having food rather. ECG showed T wave inversion in V1 to V5. Echo showed normal systolic function and then no regional wall motion abnormalities, but you see this troponin is elevated 2156 picogram. You can see there are T inversions in most lead 1, 2 is there, AVL is there, almost V2 to V6. It's T inversions are seen. Little non-rising R is there up to V3. And let us look at his investigation. Hemoglobin normal, TC normal, platelet count is 1.23 lakhs, total cholesterol 159, triglycerides 92, LDL is also almost normal, but HDL is low, 36 in a and he is LPA. Normally it should be less than 30. He is 78, almost like a high risk only. And creatinine is also little borderline, 1.26 almost, and sodium potassium is normal, and see yeah, diabetes 7.5, little uncontrolled diabetes is also there. And the angiogram CAG showed a single vessel disease. As you can see here, you can see this the proximal LAD is showing a definite lesion is there, and he underwent rather PTCS stenting. So initially balloon dilatation was done, a stent was put there, and see you can see that a good TIMI 3 flow was obtained following the stenting. So he was given aspirin 75 milligram, a ticagrelor which is a P2Y12 receptor inhibitor, 90 milligram BID, almost a moderate intensity statin, atorvastatin 40 milligram was started, and he was given a beta blockers, and he was continued with anti-diabetic drugs to see that the sugar also comes under control. And because he is also a diabetic and a ischemic heart disease, we added ACE inhibitors also. So that was one case. So let me take an example of another case. See this 43 years old male, I told you in India, even it is becoming more common amongst the youngsters. So he used to get chest pain on exertion since almost recently, 1 month, and of recently getting chest tightness even at minimal exertion, and sometimes even at rest also. His resting ECG was normal, his troponin was positive. So that's why he has to undergo an angiogram just to see what is happening inside. Blood pressure and clinical examination was normal. His BMO is also normal, and routine investigations were normal. And what was important is strong family history of his own brother having a coronary artery disease, and he had undergone it. PTC and stenting in the family. So again, a strong family history was there. What was his lipid profile? Cholesterol was 195, total cholesterol. HDLC was low. LDLC was higher side. Non-HD is HDLC is also on a higher side. Triglycerides almost to normal, but still we expect the triglycerides to be less than 100, and VLDLC is also normal. I told you in India, sometimes the HDLC is low in almost 70%. Triglycerides are also high. So because this metabolic syndrome type of this thing is little more common. So he underwent coronary angiogram. As you can see there is a proximal LAD, mid LAD disease is there. Here also there is a lesion. And you can see even the LMC is little narrowed. I told you LAD already. So here also there is a disease. So multiple lesions are there, and even in the RCA there is a little mid non-significant, but distally also in the PDA there is a disease. So because of the triple vessel disease, of course, even though he is young, he may require 3 to 4 stents, and the repeat procedures are more common with stents, and restenosis is also a little more common, and hence was advised bypass surgery as a first option or a high risk triple vessel PTCA stenting procedure. So, what is the pathophysiology? It is a rupture of the plaque, and once there's a T cell hyperreactivity is there, and disruption, erosion of unstable atheromatous plaque can be there, and plaque rupture is much more common than the erosion. Erosion is more common in females. Coronary vasoconstriction can be there with superadded this thing, and progressive atherosclerosis, restenosis after a PCI can be there, and oxygen supply demand mismatch is there because there is a plaque there, there is a distally there is a less supply of the blood, and I told you already activation of platelets and tissue factor coagulation cascade leading to thrombus, but it's a non-occlusive thrombus, unlike in a STEMI, which is an occlusive thrombus. Okay, that is occluding the whole vessel. And this can be even evidenced by OCT, optical tomography also, coherence tomography, and also it can be visualized by CT angiogram or a IVUS insertion. So the symptoms I have already described to you. What is more important is in the ECG you can have a more than 0.5 millimeter ST depression or an elevation or a transient ST elevation less than 20 millimeters, minutes only. It will not persist beyond it. What is more important is a ST depression. Uh, and hence, even though initial ECG may be normal in these people, you may have to repeat ECG every hourly just to see are there any dynamic changes in the ECG, because especially in the LCX territory, ECG can be completely normal, or acute RV branches occlusion, ECG can be normal. So dynamic STT changes are very important, especially 18 lead ECG is very important, including the right-sided leads as well as the posterior leads. And biomarker rise more than 99 percentile, especially high sensitivity troponin T, done more than 3 hours or 2 samples 1 hour apart. If there is a rising trend, you have to suspect. And of course, NHS-CRP, that is high sensitivity CRP, NT-proBNP also help in the diagnosis. If they are elevated, they all indicate a high risk only. If you see echocardiogram, there can be sometimes regional wall abnormality may be seen. Rarely, even systolic, diastolic dysfunction can be observed. And of course, if everything appears fine, even they can undergo a stress echo or a myocardial perfusion imaging also may help. CCTA, if there is low or intermediate risk, even CCTA, that means computerized coronary CT angiogram also can be taken. Rarely even CMR also helps in the diagnosis. So these are some of the differential diagnosis has to be done when there is no clear-cut etiology like myocarditis, pericarditis, pulmonary embolism, fringe metal angina, sepsis, microvascular disease, aortic stenosis, hypertensive emergency, stress cardiomyopathy, what's called as Takotsubo's cardiomyopathy in all these conditions. And you can, this is another case wherein there can be a diffuse changes can be there. See here, V1 to almost V6 T inversions can be there in some of the patients. And whereas this has to be differentiated from acute pericarditis. See here, multiple leads are showing ST elevation 1, 2, 3, AVF also almost V2 to V6, except in AVR. You can see there is a depression, which is a very typical of a acute pericarditis. Of course, the typical pain and a pericardial rub will be able to, you can be able to make out the typical of a history of a either a fever, all these things. And in the coronary angiogram, you see in a unstable angina or a non-ST elevation MI, scalloped overhanging edges, narrow neck with a haziness, more than 50% in at least one vessel in 20% of the patients. LMC in 10%. Almost 35% have three vessel disease. I showed one example of a young man having a three vessel disease. 25% can have a two vessel disease, and 10% may not have significant lesion at all, especially in women. Suggestive of it could be a microvascular disease, rarely just an endothelial dysfunction, when the prognosis appears to be good in such people. So in them, it can be 2.2% 30-day death or an myocardial infarction can be there. Whereas with obstructive CAD, the death or MI in at 30 days is 13.3%. That's why you must know what is the extent of the underlying coronary artery disease by coronary angiogram, all these things. Of course, IVUS and OCT, they guide plaque morphology and etiology and help in the management also. What is natural history? Unstable angina has a lower short-term mortality. I told you less than 2% at 30 days. NSTEMI mortality is related to the extent of myocardial damage and hemodynamic compromise. Within 30 days, MI or heart failure are common. Later, SCDs sometimes to the extent of 46% can occur. That's why you must investigate all these people because over a long term they can have a bad prognosis, and rarely even CV deaths can be there. And whereas in STEMI, which has higher rates of early mortality, is more common in STEMI. Long-term outcomes are worst with non-STEMI, depending on extent of the CAD, associated comorbidities, and previous myocardial infarction, all these things. So, how do you risk score these people? It is one of the risk score called as a TIMI risk score. You can see here, if the age is more than 65 years, one risk factor, more than 3 coronary artery disease risk factors, which I have already enumerated. If there is already a CAD known case, more than 50% stenosis, prior aspirin use if he has used already, more than 2 anginal episodes in prior 24 hours, again a high risk, and ST deviation I have already talked to you, and I told you troponin rise, very important. More the number of risk factors, more the worst outcomes. That's why this risk helps Q2. If it is just 0, 1 or 2, it is a low risk, whereas 3, 4 and above, definitely a high risk. They have to undergo a coronary angiogram. What are the drugs we usually use? Aspirin, initially loading dose, and for any intervention, we also load with the V2Y1 inhibitors like ticagrelor or prasugrel in young people, whereas elderly people, clopidogrel loading dose, all these things. If the bleeding tendency is more, only clopidogrel also can be added to the aspirin. Anticoagulants like heparin, LMWH are very important in the early stages because there is a thrombus and further thrombus formation has to be prevented. Nitrates are used only for the chest pain. Beta blockers like metoprolol, carvedilol are equally important. ACE inhibitors and ARBs are also equally important. And sacubitril valsartan, if there is a LV dysfunction, they may be able to help. SGLT2 inhibitors for diabetes or a heart failure management, they definitely are help. Lipid lowering drugs, high or moderate intensity statins have to be used. What is high or moderate intensity? Rosuvastatin 20 to 40 milligram and atorvastatin 40 to 80 milligram has to be used. Sometimes in combination with ezetimibe also. So very high risk, definitely they have to undergo. What are high risk? If there is hemodynamic instability, cardiogenic shock, recurrent or refractory chest pain, life-threatening arrhythmias, mechanical complications of myocardial infarction, acute heart failure, or ST segment depression, more than 1 millimeter, more than 6 leads. They are very high risk and they have to undergo immediate invasive management within 2 hours. Whereas high risk features like NSTEMI with a dynamic new or presumably new STT changes and resuscitated cardiac arrest if it is already there without ST segment elevation and cardiogenic shock or a grace risk score. Risk scoring also is done with a grace score more than 140. They have to undergo at least an early invasive uh, management. And low risk, you can just continue with this thing, but better to assess them also how much CAD is there. Now let us just go on to the STEMI patients. A 74-year-old female, hypertensive, complaints of chest pain and epigastric discomfort since 12 hours, ECG sinus rhythm, ST elevation was present in V2 to V6, 1 and AVL, ST depression with T inversion in AVR, echo showed regional wall motion abnormalities involving mid and distal IVS, LV apex, and anterior wall, and EF of a 35%. Already there is a LV dysfunction is also there. Definitely a high risk features. See this elevation, lead 1, AVL, and see even V2 to almost V6, there is a elevation. So investigation showed little mild anemia 12.6 hemo, a little TC is higher side, 2.92 lakhs for the platelets. See the TC, triglycerides, LDL, all these are almost normal within limits, whereas HDL is low again. LPA, higher side again 92, again a high risk. And sodium was little lower side, potassium lower side, HbA1c was almost normal. So after correction, he also was given all the treatment like aspirin, a loading dose, ticagrelor, and his angio showed, see there's a cutoff of the lady, there's a lesion at the D1 also, and there's a proximal LMC also. You can see there is a thrombus there, filling defect. So in the RC also there's a almost mid RCA, there's a definite diffuse disease is there. And see he underwent mid LAD balloon dilatation, then underwent stenting. See the stent has been put here, and he also underwent proximal LAD LMCA stenting also. See this LMCA to LAD stenting also. So you can see there's a good flow was obtained following the primary PTCA which was done, as there was a continuing pain, definite ST elevation, all these things, and almost 12 hours. So let us discuss another case. 40-year-old male patient, hypertension, newly detected diabetic, almost HbA1c was 8.7, smoker, had a history of chest pain radiating to bilateral shoulder 2 days ago, admitted elsewhere. ECG showed T inversion and ST elevation. 2D echo revealed regional wall motion abnormality in the inferobasal wall and normal LV function almost. Treated the patient with dual antiplatelets, statins, and referred for further management of our center. And you can see again ST elevation in 2, 3, almost little Q waves are also there. AVF, you can see here And lab investigation, HB is little higher side because he is a smoker, and create normal, cholesterol little higher side, LDL-C almost normal, homocysteine it is higher side again, and lipoprotein is also very high. So all these are high risk features only, and HSCRP is also high, 4.7 milligrams. See, all these are very abnormal. That's how I think he, because he is also a smoker. So LMC, LAD, and L6 are almost normal. You can see here in the mid RCA, definite filling defect is there, and almost like a grade 2 to 3 TIMI flow is there. Again, you can see this filling defect. Again, suggests to have a thrombus. After admission to the hospital, patient was, after giving all the anticoagulants, the antiplatelets, all this thing, he was asymptomatic. And of course, CAG was reviewed in view of a thrombus in mid RCA with a distal TIMI 3 flow. He was treated with dual antiplatelets, statins, anticoagulants, and tirofiban infusion. Again, a strong antiplatelet agents which was given for 24 hours. Meanwhile, workup for the risk factors were also sent. Patient was discharged after 2 days and continuing anticoagulants for another 3 days. Dual antiplatelets, statins, ACE inhibitors, all continued. B6, B12 supplements was given, and folic acid supplements were given, and SGLT2 inhibitors and other oral antidiabetic medications were continued. See, after 2 months, he was almost asymptomatic. We called him for the re-angio, almost full, very, very minimal lesion, no, non-stentable rather. You can see full good flow is obtained. So, as the patient was lacking signs and symptoms of ongoing ischemia and had TIMI grade 3 flow in the RCA, we opted to defer the stenting, avoiding any thrombus manipulation because it can lead to embolism. So deferring or more correctly delaying stenting after achieving TIMI flow grade 2 to 3 in STEMI, patient has been evaluated in randomized trials, and as patient was lacking signs and symptoms of ongoing ischemia, had a TIMI grade 3 flow in the RCA, we opted to defer stenting, avoiding any thrombus manipulation. So that's why it carries the theoretical advantage that allows time for the antithrombotic therapy to reduce the thrombus burden and thus periprocedural complication. Deferred stenting reduced periprocedural adverse events, including slow or no reflow, which can occur following stenting sometimes, especially in a LAD, at the expense of a considerable risk, estimated to be 2 to 4% for vessel reocclusion during the watchful waiting period before stenting. So in this case, a deferred stent, that means stent was not put, but only the medical management was continued. So triple antiplatelet therapy with the administration of aspirin, potent P2Y12 inhibitor, ticagrelor or prasugrel, and a glycoprotein 2B3 inhibitor. All those things they were continued for 48 hours. Tirofiban, I told you, in combination low molecular weight heparin or fondaparinux is a reasonable therapeutic scheme during the watchful waiting period. Of course, optical coherence tomography (OCT) has been used as a decision-making tool in patients with STEMI and residual angiographic diameter stenosis of about 70% since less than 70. Due to its high resolution, it can delineate the underlying pathogenetic mechanism. Is there a plaque erosion or rupture? All these things. Furthermore, it can reliably recognize the presence of a thrombus as well as its type and measure its dimensions also. So, in the clinical scenario of a plaque erosion, I think better management is deferred stenting is the best way to manage. So, just to remind you of the ST segment elevation. So, usually contiguous leads you expect in an ST elevation MI, except in V2, V3 you expect more than 2 millimeters in men and 2.5 millimeter younger than 40 years old men and 1.5 millimeters in women. But 1 millimeter in two contiguous leads, that is the criteria we apply. This is the type of the ST elevation It could be convex, straight up sloping, straight horizontal, straight down sloping. All these are indicative of a acute myocardial infarction. All the types of these elevation, okay, and not this type. It's a concavity upwards, which is unlikely to be MI. Later. So this is just an example of inferior wall MI. 2-3 AVF, there's an elevation, okay, with a ST depression in the anterior leads. This is acute inferior MI with a C here, ST elevation is there. 2-3 AVF. And there's a complete heart block is also there. I'm sorry for that. See, P waves are more than the QRS complex. There's a complete heart block is there. So this is a acute inferior and RVMI. See, you can 2-3 if there's an elevation, and RV to V3 and V4 are showing ST elevation. That's why I told you RV leads are equally important in all the chest pains as well as the posterior leads V7, V8, V9. So this is acute anterior wall MI. Again, we can see maximum elevation V2 to V6. So this is anterior MI with an RBBB pattern, RSR dash pattern with a ST elevation here. So just to remind you, if there's a ST elevation lead V1 to V6, it could be LAD of the branch occlusion. Lead just V1 to V4, it could be septal branch occlusion. One AVL V5, V6, it could be obtuse marginal branch occlusion or a D1 occlusion. One end AVL alone, just a diagonal branch occlusion can be there. So depending on that, you can make out where probably is the occlusion of the coronary artery disease. And of course, troponin, I have already talked to you. Sometimes I told you troponin can be elevated with a little ECG changes in myocarditis, myocardial contusion, pulmonary embolism, pulmonary artery hypertension, catecholaminar high stress cardiomyopathy, sepsis, stroke, subarachnoid hemorrhage, and all this CKD also. That's why you should be a little careful. Of course, the you can see here regional wall motion abnormalities also are important in a myocardial infarction, STEMI as well as in the non-STEMI. And if there's a LVEF is less than 40%, it influences the therapy and suggests more severe CAD. And definitely they all need the immediate angiogram and it's further this thing. And right ventricular infarction is almost complicates 1/3 of the inferior wall MI, and usually it indicates a proximal occlusion of the right coronary artery. Mortality is high with RVMI. So what they need is more fluids immediately and avoid the nitrates in these people. Otherwise they can develop hypotension. So what guidelines to recommend in STEMI is primary PCI within 120 minutes of the diagnosis of STEMI as the preferred reperfusion method to improve survival and decrease the rate of recurrent infarction and also to decrease intracranial hemorrhage compared to the fibrinolytic therapy. But when there is a delay in PCI, if the PCI center is not available or a long distance or there is a traffic jam is there, then you must immediately go ahead and do the fibrinolysis. So as per the guidelines, within 3 hours, definitely primary PCI is the preferred, and also within 12 hours, primary PCI is the preferred method, whereas within first 1 to 2 hours or 3 hours, even continuing pain up to 12 hours, if there is no facility for a primary PCI, fibrinolysis can be undertaken immediately. So why PCI is better than lysis? Primary PCI was lysis for see here, meta-analysis of almost 23 trials. Compared to the thrombolysis, the events are much better with the primary PCI. That's why you must prefer primary PCI as the primary method for reperfusion. Thrombolysis is effective in 40 to 60%, whereas primary PCI is effective in more than 90% of the patients. Thus, comparing thrombolysis versus primary PCI is comparing a semi-effective therapy versus a fully effective therapy. The mortality benefit derived from the primary PCI strategy is not related to the fact that the underlying stenosis is removed. The mortality benefit of primary PCI is caused by the simple fact that primary PCI is twice as effective as thrombolysis in opening the artery. That is the main importance of the primary PCI. Hence, if there is a, for example, if there is a non-PCI center, then if there's a time delay in transfer, if the it can be reached, and if the primary PCI can be done within 120 minutes, and especially the procedure is done in less than 90 minutes, that immediately you can transfer if the transfer time is almost just within 30 minutes. Whereas if the transfer time is more, and if you think that it is taking more than 120 minutes, then within 10 minutes, what is more important is, I told you within 10 minutes, ECG has to be done. It should be relayed and make the diagnosis of STEMI. And if the time delay of transport is more than 30 minutes, don't wait. Just go ahead with the thrombolysis therapy. So less than 10 minutes STEMI diagnosis. Non-papers, if there's a PCI center, then within 60 minutes, reperfusion has to be done. So time is muscle. Don't delay. Do the intervention if it is feasible. If not, just go ahead and do the thrombolysis. Primary PCI, can it be performed within 120 minutes from the STEMI diagnosis? Most of the patients present in the peripheral centers. Delay in transfers is traffic, congestion, distance, unavailability of catheterization facility, lack of skilled personnel. These are all the problems with the primary PCI. In high income countries also, 25 to 50% of patients get primary PCI within 120 minutes. Whereas in our country, probably low and middle income countries, nearly three-fourths still are treated with fibrinolytics, and in India it's almost 80 to 90%. So, indication for fibrinolytic therapy, ischemic symptoms less than 12 hours, class 1A. Evidence of ongoing ischemia, still if it is there 12 to 24 hours after the onset of symptoms, and a large area of myocardium at risk or hemodynamic instability, when there is a feasibility of primary PCI is not there, it is 2A, C evidence. Okay, so this is what is the evidence, and these are the fibrinolytic drugs. The best drug is a fibrin specification, like tenecteplase, 0.5 milligram per kg body weight within 10 minutes. Just a bolus has to be given. Rarely even altiplase, but it has got a complicated method of administration. As you know, streptokinase, comes in the powder to be dissolved in 100 ml of saline to be given over 30 to 60 minutes and observe for hypotension, any reactions and arrhythmias, all these things. So you can see here door to drug time, that is fibrinolysis, as if you give within 30 minutes, the in-hospital mortality is very low. Whereas if you go on delaying the time of fibrinolysis, again the mortality is going to be quite high. That's why it should be administered as soon as possible. What is successful thrombolysis? Relief of pain, resolution of ST elevation by at least 50%, new reperfusion arrhythmias like accelerated idioventricular rhythm or a VT, they may indicate that probably the vessel is open. Early rise and peaking of cardiac enzymes and attaining hemodynamic stability is very important. They all indicate that there is a successful thrombolysis. And you can see here almost 29,000 patients, a meta-analysis fibrinolytic therapy trialis collaborative group, seen whether it is anterior MI, inferior MI with bundle branch block, or even up to 12 hours, or rarely even up to 24 hours with ischemic symptoms at any age for that matter, gender non-specific, any blood pressure including hypotension less than 100 to the even up to 175, any heart rate. So you can see that definitely there is a benefit even with a fibrinolytic therapy, and 18% proportional reduction in 35-day mortality, and is highly statistically significant. That is the importance of doing a fibrinolysis if the primary PCI is not feasible. Bleeding complications just hardly 1 to 12%, and major bleeding is very less common. ICH is the most serious, but again it is also less than 1%, but varies with the clinical characteristic of the patient and the fibrinolytic used. That's why if there's an advanced stage, you have to give half the dose of fibrinolysis, not the full dose as we give less than 70 years. 70, 75 years, you must give 75 years and above half the dose of fibrinolysis. And especially if there is a lower weight, female sex, prior cerebrovascular disease already, systolic and diastolic hypertension, you should be more careful. And intracranial bleed hardly in 0.9 to 1% of the patients. And minor bleeds are common, major bleed is little rare. What is failed thrombolysis? If there's a continuing pain even after thrombolysis, worsening ischemia is there, the ST elevation has not subsided more than 50%, ST segment resolution less than 50% in chest leads, and less than 75% in inferior leads, and an ECG done at 60 minutes. They all indicate that there is a fibrinolysis failure. Hence, he should be shifted to a higher center where PCI facilities are available. Shift for a rescue PCI. So post-thrombolysis, transfer routinely to a PCI center for a coronary angiogram. Even after successful thrombolysis, within 2 to 24 hours, the patient will need an angiogram just to know what is the underlying CAD extent and what has to be done. Ensure that an ambulance is on standby when you decide to thrombolyze. Monitor, defibrillator, oxygen, and a doctor should be sent along with the patient. Call the hub hospital ahead of time while you are sending. So, what are the routine medications? I have already talked to you. Dual antiplatelets, especially in young people, P2Y1 to strong P2Y1 inhibitors like ticagrelor, prasugrel can be used. If the bleeding tendency is more, even clopidogrel. Elderly, better to use clopidogrel with a aspirin. Anticoagulants, I told you, following PCI, there's no need except if there's a complex procedure, all these things. Otherwise, up to the time of PCI, LMWH heparin can be given. Nitrates only if there's just a pain. Beta blockers, of course, any of them, metoprolol, bisoprolol, carvedilol can be used. ACE inhibitors are also must, especially if there's a diabetics and MI patients. MRAs, if there's a LV dysfunction, that is mineral receptor antagonist like eplerenone, all these things. Sacubitril valsartan can be used in LV dysfunction. SGLT2 inhibitors for diabetes control as well as heart failure management. And glucose lowering drugs, especially gliptins, are also helpful. Lipid lowering drugs, I have already talked to you. High dose statins, even sometimes including combinations like ezetimibe and bempedoic acid, just to lower the LDL below 50 milligrams, preferably 30 milligrams if there's a high risk CAD patient. So, what is secondary prevention, which is very, very important? Lifestyle modification, including the diet control, weight control, physical activities, then antiplatelets have to be continuous. After up to 1 year, dual, later at least one antiplatelet like aspirin can be given. Statins, of course, again, to see that the LDL should be maintained below 50 milligram in already those suffered MI or ACS. Beta blockers, I have already talked to you. ACE inhibitors helps the remodeling process of the ventricles and also long-term prognosis, and comorbidities treatment like hypertension control less than 130/80 millimeters of mercury, lipids I told you, and diabetes control to target levels as advocated in the guidelines have to be maintained. I think with this I conclude my talk. If there are any questions, I'll be very happy to answer. Thank you. I thank the IGCP once again for having this given this opportunity. Thank you.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Oh, definitely.
Sure. So, sir, the first question is, how does the risk profile of NSTEMI patient compare to that of STEMI patient?
I have already told you NSTEMI risk profile, especially those who come with a hemodynamic instability, blood pressure being low, cardiogenic shock, LV failure if they are in pulmonary edema, and if they are developing arrhythmias, they are all high risk patients. And if there's a quite rise in the and also LV dysfunction on the echocardiogram, all this indicates that he may be having a severe disease, and they should undergo immediate intervention like coronary angiogram within 2 hours if possible, or else at least give the immediate treatment and send them for a PCI center wherein angiogram can be done. And if there is a necessity, they will be able to do the interventions accordingly. And similarly, ST elevation MI, again, TIMI risk score is also going to help there. And of course, all ST elevation MI, they have to take the proper treatment, and also they should also undergo angiogram immediately so that you can risk stratify them. And of course, the same thing applies. Again, there also there is what is called as a TIMI score for ST elevation MI is also there. Less than 4 is a low risk. For 5 to 9 is a intermediate risk. More than 9 is a high risk in the case of a TIMI for the STEMI people. So we can risk stratify them. And of course, in a simple term, I can tell you hemodynamic instability, presence of arrhythmias, presence of a LV failure, presence of a pulmonary edema, all this indicate that high troponin levels, high CRP levels, all this indicate that they are also having a high risk, and they should be treated immediately with all necessary drugs at your level, and they should be sent for angiogram.
Thank you, sir. The
Yes.
next question is, how does the use of biomarkers differ in the early detection of NSTEMI versus STEMI?
Biomarkers. Always we use high sensitivity troponin. That is the one we use, not the CKMB. People may think CKMB may help, but it doesn't. What we advocate, and as per the guidelines, high sensitivity troponin is the one which we believe. And if it is raised more than 99 percentile, or if you have done two troponin levels 1 hour and 3 hours apart or 2 hours apart, if there is a rising trend or a fall, all these dynamic changes in the troponin levels also indicate that is a high risk feature biomarker. Of course, high sensitivity troponin, C-reactive protein also may help. And NT-proBNP. If the NT-proBNP is raised, it indicates that there is an LV dysfunction. And again, they are at high risk. So these are the biomarkers we use in the diagnosis.
Thank you. So there's one last question. How
Yeah.
does post-discharge management differ for NSTEMI and STEMI patient?
I don't think any much difference is there. Same way you have to manage both the patients, because if there's an underlying CAD, I told you antiplatelets has to be continued, especially the aspirin after 1 year. Before 1 year, it is dual antiplatelets, depending on the age, bleeding risk, all these things, which I would talk to you in the my talk, and that is during my speech. Then beta blockers, especially if there's a preserved LV function initially, and of course more than 40 or 50% EF, beta blockers in the long term may not be able to help, but especially in the acute events, if there's a arrhythmias or if there's a LV dysfunction, definitely beta blockers like metoprolol, bisoprolol, and carvedilol are going to help. ACE inhibitors have to be continued almost lifelong. Statins also need to be continued almost lifelong to keep the LDL levels I told you if they have suffered from CAD, if the CAG lesion is already existing or a stent has been put, they should have an LDLC below 50 milligrams, preferably in high risk patients below 30 milligrams. And of course, blood pressure maintenance less than 130/80 millimeters. LDL I have already told you. Then sugar, if they are diabetics, they should be fasting should be 100 to 110, and post lunch it should be always 160 to 180 within that range, or HbA1c being less than 7 always. And along with this, of course, physical activities, walking is a must, no smoking, no alcohol, all these also, and also body weight maintenance. Especially keep your BMI within 22.9 for Asian Indians, or measure your waistline and bring it below 80 in a female, below 90 in a male. Along with this, stress management, sleep is also equally important. 6 to 8 hours of sleep, and stress also has to be reduced by meditation, yoga, all these things. So this is the rehabilitation which is required for both NSTEMI as well as ST elevation MI. Thank you.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, sir, before concluding, any take-home message from your end?
Any chest pain, especially with the risk factors like diabetes, hypertension, a smoker, a strong family history, above the age of 40 years, or even sometimes young people, smokers, if the strong family history is there, all diabetics, or if the cholesterol is, if once it is measured, if it is more than 180, a single measurement of LDL more than 180, you should be very careful, and you should undergo all the investigation just to rule out a CAD. And once if there's a chest pain, immediate ECG has to be taken. If there are dynamic STT changes along with a chest pain which is beyond 20 minutes, you must get a troponin levels. If the troponin is raised, you must send them for an angiogram and assess them. If the troponin is low, still if they are getting pain, they have to be investigated non-invasively by a treadmill test. If the treadmill is positive, again you may subject them for angiogram. If treadmill is negative, advise them the lifestyle modification, including stress management, sleep pattern, diet management, habits, all these things. With this, I think probably I have answered most of your questions.
Yes, sir, definitely. And thank you, sir, for joining us today for this wonderful session. Thank you once again. Thank you, sir.
Thank you.